This session covers the metrics and outcomes that pharmacists can impact. We'll cover barriers to evaluating pharmacist value, clinical team efficiency and satisfaction, patient engagement, quality, and cost. One barrier to implementation or expansion of ambulatory clinical pharmacist services is the ability to demonstrate the value and outcomes of these services. Pharmacists and clinics often practice in team-based care. While this helps improve overall patient outcomes, this can make it challenging to identify the pharmacist's individual contribution to those outcomes. In the inpatient setting, pharmacist services are often tied to finite metrics, such as doses dispensed, orders verified, lengths of stay, or therapeutic drug monitoring. Ambulatory pharmacy services can be harder to define and quantify, but the ability to demonstrate these outcomes can affect reimbursement and value-based payments for the organization. Physicians attributed many benefits to having a pharmacist integrated into their practice, including having a colleague who is able to provide reliable drug information, optimize medication prescribing, improve clinical documentation, services, and recommendations, and enhance the patient care. Clinical outcome metrics demonstrate the value of the pharmacist in providing direct patient care. As the nationwide trend and reimbursement models shift from fee-for-service to pay-for-performance, the ability to share timely and impactful outcomes with stakeholders is imperative. However, consistent and validated metrics for ambulatory clinical pharmacists can be challenging to define, given differences in state practice acts, administrative codes, and statutes that dictate practice. Additionally, the team-based care model may further blur the lines of the direct impact on clinical decisions made specifically by the pharmacist. While these four differences can affect the ability to compare metrics across different states and organizations or set external benchmarks, tracking metrics is important for internal benchmarking, physician justification, and workforce expansion. Within the clinic setting, ambulatory care pharmacists may enhance provider access by offloading clinic visits from the provider schedules, which allows providers to see more complex patients and build their panel size, thus increasing the total revenue of the practice. One method to track this includes the third next available appointment for the providers. Ambulatory clinic pharmacists may be responsible for more indirect care than physicians or other advanced practice providers. Measuring this generally unreimbursed work removed from physician responsibility can show improved clinic efficiency and physician productivity. Also, pharmacists responsible for indirect work can improve clinic team efficiency, morale, and well-being. Although metrics that are consistent with other provider types will be well understood and valued by hospital leadership, it may be useful to develop pharmacist-specific metrics that help to define the value of pharmacists on clinical teams. In addition, lack of clinical billing and reimbursement for pharmacist practice make it necessary to collect and report data that demonstrates cost avoidance or other return on investment metrics specific to pharmacist practice. Pharmacists working in clinical practices can measure and report productivity metrics relative to their clinical practice. Pharmacist practice measures that are comparable to other provider types include measures like the number of new referrals received, visit volume per FTE, the visit type, if it's face-to-face, video, phone, the number of active referrals, their third next new visit, patient satisfaction or provider satisfaction. If the pharmacist can bill for their services, that adds a few other measures like their actual visits divided by their budgeted visits, their actual revenue over their budgeted revenue, or their annual RVUs or average RVUs per visit to demonstrate value and complexity of care provided. Some productivity measures specific for the pharmacy could be around medication initiation or modification, discontinuation, the number of labs ordered, the number of pharmacist notes entered in the EHR or messages sent through the EMR, the time spent per patient, the pharmacist intervention tracking tools, or physician satisfaction with the pharmacist services. Improvements in health outcomes at the individual and population health level also demonstrate and have also been demonstrated in multiple studies when pharmacists work as a member of the interprofessional team, as well as decreased fragmentation within the healthcare system, with the pharmacist working as like a bridge between the silos. A final reminder from session 5 about the VA using pharmacists, which resulted in improved team satisfaction and saving primary care providers 20 minutes on average with their new patients. Research around the world supports that patients prefer to have their care coordinated between a physician and pharmacist, and recognize that this collaboration is integral to optimizing their care. Patients expressed a sense of companionship with the pharmacist, which improved the patient's desire to reach their healthcare goals. Patients and caregivers communicated the benefits of having a comprehensive medication review in their interdisciplinary setting. This includes a decrease in inappropriate medication use, optimization of the hypertension and diabetes meds, as well as minimization of antipsychotic use for the behavioral and psychiatric symptoms of dementia. When primary care practice pharmacists provide medication education and information, many patients feel that the medication-related education and the disease-related education and delivery of that education is excellent. The appointment-based model increases PDC by 20% for all their chronic conditions, all their chronic meds, and that increases the odds of adherence by 3 to 6%. Also under the appointment-based model, the patient had fewer trips to the pharmacy, but more engaged conversations with the pharmacist during those trips. And so that led to more vaccinations, counseling, and diabetes management. There are a number of healthcare quality organizations who define clinical quality measures that pharmacists can impact. Examples of healthcare effectiveness data and information set, or HEDIS, and CMS measures that ambulatory care pharmacists can impact related to provision of effective care are on this graphic here. Notice how everything under primary care is checked. And this is just a section, actually, of the full list. That's about half the list. And they're all the way down. All the rest are checked as well for primary care. While HEDIS measures provide surrogate markers for current health status, the utilization metrics most accurately demonstrate extent and cost of disease burden and progression. Examples of HEDIS measures on risk-adjusted utilization that pharmacists may be able to impact are plan all-cause readmissions, hospital following discharge from a skilled nursing facility, acute hospital utilization, emergency department utilization, and hospitalization for potentially preventable complications. Clinical pharmacists can also partner with you to improve the quality of care by using clinical registries to focus on granular measurements of defined populations, lab markers, and disease entities. They help you demonstrate quality, which is becoming increasingly important as fractional differences in reported performance can qualify you for bonuses or trigger huge penalties. The key to representing quality includes keeping up to date with current quality campaigns, knowing the numerators and the denominators of the highest priority quality measures, and accurately attributing patients to the correct clinicians and the correct groups. These responsibilities can be delegated to clinical pharmacists, as I've personally done in the past. For many metrics, the last documented measure of the year is the one that counts most. If you're working with one clinical pharmacist, it may be worthwhile to use that first quarter for medication safety projects and then use the final quarter to fill lab gaps and reschedule patients for blood pressure rechecks. Pharmacist integration into primary care practices have been shown to improve an array of healthcare outcome quality measures, from appropriate medication use and prescribing to reduced healthcare utilization and medication costs. And now here we have the final boss in healthcare that has proven to be particularly difficult to beat: cost. Pharmacy leaders should partner with payer organizations to identify areas for improvement within the organization to optimize value-based payments and reduce total cost of care. By achieving specific population health-based metrics such as A1C and blood pressure targets, institutions may qualify for additional incentives for meeting such goals. For institutions that are self-insured, the ambulatory care pharmacist could assist with optimizing employee health outcomes in an effort to reduce admissions or readmissions to decrease the total per member per month costs. Ambulatory care pharmacists are uniquely skilled in decreasing medication costs and improving medication access. Pharmacists may use their knowledge base and skill set to make therapeutic changes or provide deprescribing or polypharmacy services to reduce the overall drug spend, which may impact drug spend for both the patient and the health plan directly, instead of having to get it from reduced medical spend on the medical side. For medication therapy management, or MTM, generally the ROI can be from 1.2 times to 25 times or higher, depending on the exact services and the calculation method. This ROI comes from the decreased medical spend, the decreased or increased from better adherence, the pharmacy spend, fewer hospitalizations, ER visits, and improved quality of care. Even with increased primary care usage, pharmacists integrated into primary care decrease ER visits and medication costs, reducing the overall cost of the healthcare system. This session covered the metrics and outcomes that pharmacists can impact. We covered barriers to evaluating pharmacists' value, clinical team efficiency and satisfaction, patient engagement, quality, and cost.